Okay, good morning, everyone. We're going to go ahead and get started. Thank you all for being here. We have a really special treat for you today. So we are being joined by Dr. Cathy Bradley, who is professor and dean of the Colorado School of Public Health, as well as the deputy director of the University of Colorado Cancer Center, where she also holds the Paul Bunn Chair in Cancer Research. So prior to joining the University of Colorado, Dean Bradley was the founding chair of the Department of Healthcare Policy and Research for VCU. She's a health economist and received her PhD and MPA from the University of North Carolina, Chapel Hill. She has served on the National Academies of Science, Engineering, and Medicine's National Cancer Policy Forum, and formerly served on the National Advisory Committee to AHRQ. She currently serves on the Methodology Committee for PCORI. Dr. Bradley has received numerous awards and honors, including the Women in Science, Dentistry, and Medicine Professional Achievement Award in Leadership. And she maintains an active research portfolio of NIH and foundation-funded grants, where she leads research related to cancer disparities in outcomes, financial burden, and labor market outcomes of cancer survivors. Please join me in welcoming Dean Bradley.
Good morning, everyone, and thank you for that introduction, and thank you for the opportunity to be here. I'm so fortunate to have had 2 beautiful days in New Haven. It's just been fantastic. I'm happy to report that I did get to try the pizza. Everyone, when I told them I was giving a talk here, they were saying, make sure you get out and try the pizza. So yesterday morning, that's what I had for breakfast. And this is not my first time being in New Haven and giving grand rounds at Yale. The first time I did it was probably 20 years ago. I was an assistant professor at Michigan State University, and Dr. Ruth McCorkle, who was a professor in nursing, invited me out. And the room was entirely different. And I was telling Michaela about it, that it was in this room that was like a well that looked down where they used to do the old grand rounds with the patient down below. And it had to be probably one of the most intimidating things I've ever done, being there as an assistant professor and then sort of in that particular setting. But it is fantastic to be back. I titled my presentation, The Winding Path Between Medicaid and Cancer Health Disparities. And that's because nothing with Medicaid is straightforward. And certainly nothing with cancer is straightforward. That too tends to be quite circuitous. So before launching into the presentation, I want to sort of go ahead and do the spoiler alert and talk about the 3 things that I think are takeaways. The first is just the complexity of the problem. And I think as researchers, we like a good problem, you know? So this one is a particularly good problem that is something with lots of facets. And as you think about your own research, especially if you're doing disparities, it's hard not to talk about Medicaid and Medicaid coverage. It's probably our best hope for narrowing disparities that just seem to be widening no matter what we do. But it does provide coverage to a population that so desperately needs it. And so understanding the program is pretty critical. And in places that haven't expanded Medicaid or really maligned against the Affordable Care Act, one of the arguments you frequently hear is substandard care. It's just terrible health care. And whether that's true or not, it's something that is said frequently, and it's up to us to figure that out. And if it is substandard in some places, where are those places and how do we improve it in our policies? So that's the first area, is to really think about this problem. The second thing is around data. And we all need data to do our research, but secretly we hate data because it's so hard to acquire. And once we finally get it, we get it from these agencies that are holding data that aren't meant for research. We take it and we're clever, we're going to merge it with different data sets and stuff. But now what do we have in front of us? And it's understanding that data and the importance of doing so. And then the final takeaway is really all about the data infrastructure. And by not having a good infrastructure, because our health system in the United States is so incredibly fragmented, that we don't have a comprehensive data infrastructure that we can just pull down and understand what's happening with the quality of care, especially with those who most need it. So at the end of the presentation, I leave time for questions. So please be thinking about those questions. I really love that part, and being able to have a discussion. I think that's the most interesting thing. So going forward. First, I'd like to just acknowledge the wonderful people I have the pleasure to work with: Marcelo, Rich, Sarah, and Faye, all from Colorado. Lindsay Sabik, University of Pittsburgh. Always love working with her. And then our colleagues at the Cancer Registry and Civic, who holds the all-payer claims data. Colorado is one of the few states that have an all-payer claims database that's available for research. And they have been wonderful about working with us, but they are not cheap. The agenda for the talk, just an overview of Medicaid, getting us all on the same page, factors that affect cancer outcomes, specific factors about Medicaid and that enrollment that can affect what happens to you once you're diagnosed, treated, and become a cancer survivor. Then the factors that affect research, the incomplete data we might have, the nuances of our data, and the importance of understanding it. And then just to get a sense from all of you, the disparities between Medicaid and other forms of insurance what is going on there? Is it inadequate care? What do we do about it? And then wrapping up with some future directions. Nothing really to disclose except that this grant was funded by the National Cancer Institute, and Marcelo and I are co-principal investigators. So why this is such an interesting problem, and I have the puzzle pieces there because I'm guessing, like me, many of you enjoy a good puzzle, right? To figure things out. So what we want to understand is Medicaid, is it a safety net savior or this malign purveyor of inadequate care? Which one is it? So many years ago, when I was here presenting, I was actually presenting about Medicaid and cancer. Sort of the very first research I did in this area, and was trying to really understand things. And I was young and stupid in many ways, and working with the state health department around getting their Medicaid data and merging it with cancer. And it was really a complicated process, and they didn't want to let go of their data. And I have found that these individuals insured by Medicaid had worse survival. And I said something along the lines of, it's a safety net just above the grave, which did not make the Medicaid people want to give me their data anymore. And that wasn't a way to form the relationship. So an important lesson learned at that time, but it formed kind of the basis really of understanding why is it that people who are insured by Medicaid did so much worse. And was it the insurance? Was it something about them? Was it, that they had tons of comorbidities, got in late, but kind of led to this circuitous journey. So the next point of enrolled too late and lack of continuous coverage, if you come in once you're diagnosed, you probably have later stage disease and probably have other problems that aren't being cared for. So what's the right comparison group? Is it people who've had insurance all along, or people who've had Medicaid insurance all along? So anyway, thinking about that. Reimbursement. So over time, we know Medicaid reimburse at a much lower rate, even for people who are diagnosed through the CDC's National Cancer or Breast and Cervical Cancer Early Detection Program, that once they're enrolled in Medicaid for treatment of their cancer, that care is reimbursed in some states at an even lower rate than a normal Medicaid patient. So there's all kinds of things that we do around reimbursement that prohibits access. And then data complexity. Medicaid data is a mess. I mean, it is just a complete mess. People come into Medicaid, they drop off the next month. We don't know what happens to them. And it's trying to understand how they got into Medicaid. And because Medicaid is the payer of absolute last resort, you may be missing claims if they have any other type of health insurance. So Medicaid is the largest insurance program in the United States. And for most states, it is larger now than their education program. So it is just a huge program across the country, and in every state it is administered differently. Large provider of people of color, protects against major financial consequences, which is what insurance is supposed to do, is to give you that insurance against losing everything. And then this huge variability. And the graph that I show is the proportion of people by different racial ethnic groups that are covered by Medicaid. Under the ACA, we were supposed to expand Medicaid, but then it was left up to the states to do so. At this point, 10 states have still not expanded Medicaid. North Carolina is set to begin, was set to begin in the beginning of December if they are able to launch the program. So still some important holdouts with Medicaid expansion. And in those particular states, the threshold for Medicaid to qualify for Medicaid is quite low. So one of the things we used to say in Virginia was you really could not cut grass and still qualify for Medicaid. The level was 13% of the federal poverty line. Pretty astounding, right? As Medicaid expand, we do know that it provided a lot of good to a lot of people. It did increase access to care. We observed improvements in some health outcomes, and it contributed to reductions in racial and ethnic disparities in healthcare coverage. So by and large, it seemed to be doing some of the things that we had hoped that it would. We start to see improvements both in access and in some health outcomes. In expansion states, cancer survivors had greater access to doctors. And compared to non-expansion states, women had a lower odds of receiving recommended mammograms or pap smears. And expansion was associated with earlier detection and appropriate cancer treatment and reduced mortality for those who were able to receive Medicaid coverage. So this is some of the work that Lindsay Sabek and I and her colleagues were able to do, showing pre and post expansion and these differences that it made. So it does seem to be better than not having insurance and having to go through the traditional safety net of showing up at a safety net hospital. Despite these improvements, though, we know that there's some variability, that the same benefit was not seen across the board. So we have here some evidence that newly diagnosed patients, there was improved 2 years survival, but in cancer sites such as urologic malignancies, there was no change in stage at presentation. And that the thyroid cancer showed that Medicaid patients were still likely to be diagnosed at an advanced stage and less likely to receive guideline concordant care. So the picture's not really complete. We have evidence, and that's a lot of what we do as researchers. We build a body of evidence, and doesn't always agree with each other. It's the body of evidence. And we try to make the most out of the studies we have and to understand the validity, the credibility, did they do everything right? And how does this body of evidence build in one direction or other? And what we see with cancer and Medicaid, it's not initially a clear story, but there's a signal, and I think it's a reasonably strong signal, that Medicaid is beneficial. So this is where, coming back to when I gave the talk here long ago, I looked at Medicaid merged with our state cancer registry. We also merged in Medicare data as well. And we're one of the first states to do that. And my long-term colleague who is still around, had lots and lots of experience in working with data sets, very patient person, good contrast to me, especially at that time in my life. And he said, the reason we're doing this is because we don't have a meat grinder to put our hand in. And so it was kind of an interesting way to think about having to go out and get this data from the state agency who had never used it for research purposes and was in a completely different part of the state agency where the cancer registry was held. And we were just very, very fortunate that they were all willing to work together and do this and create this resource. And what we found there is that among people who were insured by Medicaid, so we have only Medicaid, the differences between Black and white women in mortality disappeared when they received the same kind of treatment. And that at the time, that's my most cited paper, interestingly enough. And it was when I first published it, most of the papers that cited it was pointing out that's not the case, that there are important racial differences. And now in recent years, the citations are, that is probably the case, that if you do treat everybody the same, you're probably going to get the same outcome. The differences aren't that great. So it was an interesting study and a place that where having Medicaid data and being able to look at people that are about the same socioeconomic status, being able to see if there are differences. So, sorry, it looks like some things got out of order. Apologies for that. So we're going to start with the enrolled too late. So why is it that despite being able to show that there are there's promising evidence towards Medicaid being a beneficial expansion for individuals, why is it that some of the disparities continue to persist? And this is a study that I did with the National Cancer Institute colleagues, where we actually took our SEER Medicare group was interested in expanding to SEER Medicaid, and we merged the two and started looking at the data. And what you find that many people don't get into Medicaid until after they've been diagnosed with cancer. And by many people, I mean more than a third or so really don't show up into the system until they're diagnosed. So they go to an emergency department somewhere, sometimes for something else, sometimes it's for symptoms. Some tests get done, find out there's cancer, and there's a social worker, financial person associated with the hospital whose job is to make sure they get paid. They figure out that the person's eligible for Medicaid and they get them enrolled. Medicaid then becomes a retrospective coverage going back and picks up the claims that occurred from diagnosis forward. When they come in at that point, it's because they're symptomatic and they're having problems. So of course, Medicaid doesn't have much of a chance to really provide them the kind of care where you're going to see the same mortality outcome, even if they have screening. So the breast and cervical cancer program is an interesting one that we were able to look at because we could see how people came into the Medicaid program. So the CDC's program has been around a long time, and it provides site-specific care. So free screening to women who do not have insurance coverage or who are underinsured, but they don't qualify for Medicaid, can get free screening. So they have a little bit more money, income, resources than your typical Medicaid insured person. So if they go through, get the screening, they are then enrolled in Medicaid for their care. And you might ask, well, gee, they have a higher income status. They don't qualify for Medicaid. They might be better off. And we'd expect them to do better than, say, the person who's been enrolled in Medicaid all along. What we did in this study is we looked at women who came in through the CDC's program. We looked at women who'd been insured by Medicaid all along and those who came in after diagnosis. And we're able to show that across the board, that those who were enrolled in Medicaid all along did better than those that came in through the CDC, those who came in after diagnosis. And Medicaid, while not the same as privately insured, and we show that here, that they are still doing much, much better. And in cervical cancer, those who were continuously enrolled in Medicaid actually did better than women who were privately insured. So we are seeing a difference. It doesn't the outcomes are not the same in terms of detection and mortality as private insurance. They're just not. I mean, these are individuals with other kinds of problems and other challenges. But if they have continuous coverage, they do better. It's the fact that Medicaid is picking them up when it's already fairly late in their disease process. And if we think of it as a public insurance program, is that the best way to spend our money? We're not going to have the best outcomes. It is expensive care at this point. Isn't it better to have them in a program continuously covered, getting screening, getting less expensive care, and having much, much better outcomes over time? We also looked at Medicaid and found across different cancer sites in Michigan that people enrolled in Medicaid after diagnosis had an 8-year lower survival rate. So big difference than compared to Medicaid enrolled continuously and non-Medicaid patients. There are other studies that have been done both in North Carolina and Missouri that has similar findings, and that they attributed it also to the timing of enrollment, and we're able to see this survival gap. The next question about the problem is, can they see a doctor? Is it these low reimbursement rates that hinder accessing care? So you give them care and they can't get in. And this was a study by one of your colleagues, Victoria Marks here, that did a fascinating study of calling and trying to get an appointment, and found that they could not get in, that many people just simply didn't accept Medicaid. Or in some safety net institutions, what they do, and they did this at VCU, which was a large safety net institution, they booked 4 people who had Medicaid insurance for the same slot that would come in, because they anticipated no shows, difficulty getting there, not coming in, and so incredible wait times. So really fascinating problem that if you don't at least get reimbursement up to the point of Medicare, may be difficult getting in. Managed care programs, a lot of states have Medicaid managed care as their approach to Medicaid delivery to try to offset some of that, to bring in a more managed program. Savick and colleagues dug a little bit deeper in this and found that a mostly positive impact on breast and cervical cancer screening with increased physician payments, and under a fee-for-service managed care plan, reimbursement had less of an impact, says that those kind of delivery plans had already was doing some things to manage and get people in. They had agreed to take on Medicaid patients to begin with, and so the reimbursement did not matter as much as you would expect. So we'll take a little breather at this point. And are there disparities? What do you think? Are there disparities in the way that people are treated on Medicaid insurance compared to other forms of insurance? So disparities there, not there? Seeing a lot of nods. Yeah, there's still disparities. Do you think it's mostly because of the timing of enrollment? Okay. Reimbursement? There are lots of nods on the reimbursement. Or is it just they do provide a poor quality of care? And this is a difficult to treat population. Is it something endogenous, in other words, there? Yeah, not a lot of people buying that particular argument. A lot of times, providers, clinicians, they don't know what kind of insurance their patient has when they get in front of them by the time they're there. And the same kind of treatment is provided. It's getting in the door is the problem. And it's once they are there, I don't think that those who actually treat them and lay hands on them really at that point know what kind of health insurance. They may know at some point in the treatment trajectory as they go forward around reimbursement rates and things. But initially that care isn't known. Okay. So let's understand the data that we're working with. The research so far, to just recap, Medicaid is an important safety net, but it does appear to have some holes. There's a problem with enrollment and continuous care. People who qualify for Medicaid aren't enrolled in the program. They just don't realize they are. Certainly in Colorado, we see a lot of people coming in who qualify for Medicaid, but they're worried about their citizenship status. And Colorado has a don't ask policy, and we just bring them in. It tends to be more general, but they don't want to approach the health system because of that. Various other reasons that we see that people are shying away, but they qualify nonetheless. So we have a problem there with continuous coverage. And then we need to understand once they get in, what is really happening? And our team then began to wonder, well, what if the data are not telling the complete story? What if there's something inherently wrong with being able to look? Because most of the research, because as my colleague said about having a meat grinder to put our hands in to get all this data, is complicated and it's costly. And it takes years of forming those relationships and being incredibly patient to get all of those pieces in place. As a result, many people use cancer registry. They use the SEER data, which they can be able to pull easy, or NCDB, other kinds of cancer registry data that they can get their hands on. And the question we began to ask, well, what if those data are not right? So turning to this part of the study is from a paper that just recently got published in JAMA Health Forum. And there we took the all-payer claims data, merged it with our state cancer registry. And for the first time, I was able to actually compare to private insurance and to be able to do lots of controls in the data to get an equivalent control group. So it was pretty exciting to be able to do this. We started off with the question of, are there treatment disparities in radiation and hormonal therapy among women covered by Medicaid compared to private insurance? And we compared what was in a cancer registry versus insurance claims, and to be able to do this. And this step of our research project, this wasn't what we intended to start to, was really our validation. We were trying to just figure out where the data good and where might some holes be. And this is a step we all do in our data, and we think, okay, we're done with that. Nobody's going to be interesting. But that ended up being the story. Our research question, we knew that the literature was filled with papers that women insured by Medicaid did not get radiation therapy. They were not put on hormonal therapy relative to women of other forms of health insurance. So we started there and we thought, okay, we're going to compare to private insurance, because this is a group that we picked women who were younger than age 65, and we were going to go through and just do this toughest comparison, private insurance where they should be getting the best care compared to a public insurance program. And there are some nuances about Colorado's Medicaid that I'll get back to, but this was the setup for our study. And here are some of the other studies that showed underuse of adjuvant radiation therapy and post-breast conserving surgery in North Carolina. And in Georgia, we see the same sort of thing. A Missouri study showed a delay in treatment and increased risk of death, and related it all to differences in treatment. We linked the cancer registry with all payer claims data. Did not take long to do the linkage. It took about 1.5 years to get the data. Getting everybody to agree, yes, you can have the data. And just as we were about to get it, the privacy officer at the state decided, you know what, we're only going to give you year of death, and year of diagnosis, not month and year. And we're saying, how exactly are we going to do survival analysis if we only have the year? And ended up in another big discussion of trying to convince the privacy officer that we could indeed have both the month and the year. And that delayed our project by another, 8 months or so. And we had to get everybody at every level involved. And eventually they ended up changing the regulation for the state, because we had one privacy officer, after everybody agreed, after we'd received the funding, the letter of support, everything, decide, no, I'm going to be really cautious today. So all of these things just to make it happen. And with secondary data, you think it's going to be easier, but it can be quite difficult. This is our 5-year linkage. We've actually updated it now, and we have it through 2021. Incredibly high quality. And with Medicaid, this was 93% overall, but Medicaid, it was 98%. They were our best data. And then we found that the APCD was reliable with treatment and insurance status when we went through and really tried to look at the quality of the APCD data. We were new to this. If we had used the cancer registry alone, we know that there are going to be problems. And all of you know as well that they collect data of individuals diagnosed with cancer, including patient and tumor level diagnosis at both date and stage. The outpatient treatment includes oral agents we know are underreported in cancer registries. It's just tough to get that data. Registries record the first course of cancer-directed treatment, and Medicaid and rural residents treatment data appear to be incomplete. And it's funny, our beautiful state of Colorado, most of the population's kind of in Denver through what's called the Front Range, Denver up through Fort Collins. And then there's the Rocky Mountains and the rest of the state, which is pretty far flung. And so the state is mostly rural and frontier. And when we think about Colorado, we think Aspen and Vail. And by the way, they're rural counties as well. Really different outcomes than your typical rural county, as you might imagine, in those particular places. And then the rest of the state being very rural, except for Denver. And we're the only comprehensive cancer center. And getting to us can be quite complicated. And you have to sort of think through all of those things when you use our particular cancer registry. We know insurance data are incomplete, and in fact, it's overwritten in the hospitals that record it. So you get the insurance at the time of when it's reported, which can change. You can come in uninsured, get Medicaid, pick it up, or privately insured and lose your insurance. And we know that it's more than 2 years old, whereas APC data is getting pretty real-time claims data in. It's able to overcome some of these limitations because you get all medical claims, pharmacy claims, dental claims, eligibility, and provider files, and you can link them. You get a unique identifier. So I know when someone moves from private to Medicaid or the other way around, and you'll be able to tell. All payer claims data is really some claims of some payers, to be completely honest. Not all payers are in there. Payers covered under ERISA are not required to submit claims, and that's about 30% of payers. Oddly enough, in Colorado, most of them voluntarily do so. So we have a somewhat near complete data. We can look at across, and in our state, it includes 36 commercial payers. Our main managed care payer happens to be Kaiser, and Medicaid and Medicare. Our cohort were women ages 21 to 63. We wanted to get them before they aged into Medicare and to see this cleanest group, the cleanest sample we could find. A SEER summary stage of local or regional breast cancer, enrolled in Medicaid or private insurance at the time of diagnosis, had continual coverage within 3 months of diagnosis, and continuously enrolled in 9 months. So I intentionally wanted to get those who'd been in Medicaid sometime prior to diagnosis. We already know there's a problem with those who come in late. Let's look at the continuous coverage people now and compare them to our gold standard, hopefully, of privately insured individuals, and see what happens. So able to control for this. And then for those who were supposed to receive radiation therapy, they had breast conserving surgery. And for hormonal therapy, it was women who had surgery and also had estrogen receptor positive or progesterone receptor positive cancer. Our methods were descriptive statistics, the standard of what you would expect. We used a follow-up time of 9 months following the month of last surgery as our observation period. In this data set, 93% of all surgeries, regardless of insurance, occurred within 3 months of diagnosis. And that gave us a total follow-up time of 12 months. to look at whether or not they received these therapies, estimated logistic regression and reported marginals for ease of interpretation. And then we compared what we saw if we used registry alone, if we used APCD, or if we used them both, what kinds of treatments they got. And did a sensitivity analysis, because one of the arguments is that those insured by Medicaid takes longer for them to get their surgeries. They can't get in, complicated lives, all those things. So we increased our follow-up time to make sure, but we still saw no statistically significant differences. And then we looked at poverty quartile and variables for clinician of whether the clinician was in a rural area, whether they practiced there. And that ended up being really an important variable, because if you're in Aspen or Vail, chances are you're going to figure out how to get to Denver and get your health care. But if the clinician treating you is in a rural area, means that you are a person who can't get to Denver, and is your care going to be different? So that ended up being a really interesting part of our analysis as well. So descriptively, just starting to look at our data, we see that there are big differences now in the reporting between Medicaid and private to the registry. The registry actually doesn't pick up nearly the amount of data that you see with the APCD. The APCD is adding a big chunk of claims that the registry never sees on treatment that's coming in. So people who are Medicaid providers aren't reporting as much to the registry. They're either in places that don't have systems in place, or that they don't have the resources to be able to get it to the registry, but there's not the kind of support that you get in the Denver and our university hospital to the registry. So huge underreporting that we initially see that could lead you to a very different conclusion. And in fact, it did. If we used our cancer registry alone, we saw that women insured by Medicaid were 4 percentage points less likely to receive radiation therapy than privately insured women. When we add APCD data in, there are no differences. So an important part of just trying to take the problem apart, and now I've got this group of people who are continuously insured. I've got a state with some geographical challenges, to say the least, and I'm not seeing differences when I'm using claims data. Hormonal therapy would do the same thing. 10 percentage point difference in Medicaid insured women, less likely to receive hormonal therapy. But when we bring in our claims data and can look at the actual pharmacy claims, there's no difference. They're still getting their same treatment as our privately insured cohort once they get in. So now this gives us a different look and a different view about these disparities and when we can get this data and have a true control group in these comparisons. Even after beating up on the data with our sensitivity analysis, we still find the same kind of results. At the end of the day, we end up seeing that despite the fact that there are differences at stage of disease at diagnosis, we really are seeing underreporting of treatment. And we tried to figure out whether that was just the provider, whether it was the location they were in, being in a far-flung part of the state, but there is underreporting. And some of the, when we compared to the cancer registry, APCD had some underreporting as well, but it was so much less. And they were able to pick up these Medicaid claims. So disparities were only observed when using the cancer registry alone. This has serious implications for if you rely on, if you go out and SEER is no different. When we did the SEER Medicaid linkage, the agreement between whatever SEER had as the insurance was entirely different. And as some of you may know, SEER no longer reports insurance data because it's so terribly unreliable. But if those are the kind of data that you're using to do disparities research, there's both incorrect data about what the actual insurance carrier is, and the data they have are greatly underreported if it's like what we observed in Colorado. There are limitations. Colorado is one state, and as I said at the beginning, there are 50 different Medicaid programs. There is something unique about our Medicaid program. We are a fee-for-service state, not a managed care, which is unusual across the state. That made us, though, feel even more comfortable with our claims data because it is mostly fee-for-service. The sample omitted women who did not receive surgery, although 93% of the women in our sample received surgery. So there probably wasn't a disparity there either. We didn't look at treatment completion and didn't measure the amount of treatment. That would be a next step. And then, as I also mentioned, ERISA covered plans are not required, but about half of them do voluntarily in Colorado for whatever reason. So here's where we ended up. Medicaid does a better job than we think. The disparities are not quite as great. The evidence does suggest the need for continuous coverage. And I think this last point is pretty important. Need to support the data infrastructure. We're providing the data that policymakers use, and in some states, and I've heard this stated in Texas, the reason they haven't expanded Medicaid is, well, it's just crappy coverage. We want to do something else, but they don't really have a good alternative or any alternative to Medicaid, and the data don't really support that conclusion. It's that we don't provide the continuous coverage. So next steps really is replicate somebody else to do the similar kind of things somewhere else. And for us to look at other sites of cancer if we continue to do this. Nonetheless, we have built a body of evidence that I think supports the policy for both Medicaid expansion and in fact to have continuous coverage and to increase our data infrastructure so that we provide the right evidence for policymakers to use. Thank you all. Thank you for your time, attention. And I think we're at the stage of let's talk.
Thank you so much for this really important talk, especially the conclusion that being covered by Medicaid is associated with similar outcomes as private insurance. And I'd like to hear you discuss a little bit more how to inform policy changes with Medicaid expansion in some of those states. Like, is this data enough, or you showed it has to occur in other states as well? How can we get the states that don't have Medicaid expansion to expand?
Yeah, I mean, it's interesting. How there can be an argument at this point against expansion and not having some care and being able to get into the system is so critically important, and to be able to show this. And our lieutenant governor, and both our governor and lieutenant governor are very much about healthcare and making it affordable. And the lieutenant governor has the awkwardly named office of saving people money in healthcare, literally. And I quote, I mean, it's just like, really. Anyway, but she has this office and really pays attention to this kind of evidence. And she herself is a 4-time cancer survivor that she says all the time, and she visits our cancer center. She is on our advisory board, comes in, and she is always talking about the affordability of healthcare and access. And for us to be able to show this data, she was completely on board and resonating with it. And they support the APCD, the civic organization that manages it and wants it to be used. If you're in a state where that's just not your philosophy, where you don't believe data, where you don't trust the data, where you're looking for ways to reduce the public safety net, it sometimes feels like there's just not enough evidence. But I think we have to keep trying, and that's our job, to be able to keep putting this out in front. When we started this part of the project, it really was that tedious validation component that we all do and then it became the story. Like, wait a minute, we're not seeing any differences. We expected to, but we're not. And then even when I mentioned this to true believers at the National Cancer Institute that run the SEER registry, they said, well, are you just getting the claims later? Or do they eventually show up in the Medicaid or in the cancer registry? No, they never showed up. Even when we expanded our linkage out to 2021, The people we saw being diagnosed in the earlier part of our cohort, their claims never made it to the registry. It just doesn't come in. And providers who are doing care for large Medicaid populations don't have the data infrastructure that's being reported up. And when I showed this to our cancer registrar in the state, he said, yeah, that sounds about right. It wasn't actually a surprising finding to him. He says, yeah, we're trying to provide more support to these other providers that we know that need it. So the infrastructure is pretty important. Yeah.
I have a question as a clinician, slightly different perspective. When our patients get Medicaid or free care, where we call it here, our team is just ecstatic because now we can actually get reimbursed. We can do the care as we would normally have it. So I think that delay to enrollment certainly resonates, but I think that once they get into our system, and then we can start to hook them up with primary care and all the things that they haven't had. So that's my perspective in terms of that piece of it, is that once we get that coverage, we're trying to provide the exact same care as we do it as our other patients.
Yeah, I agree with you completely. And I think that is the case in institutions like ours, right? If you're a private provider out in the community, especially way out in the community, you might be more sensitive to how many Medicaid patients you put on your panel. But I think what you described is very much the case. And, the key is being able to get them here and get them into these kind of centers where they're going to get really good care. And we've actually done studies to show that if you get to an NCI designated center or even a COC designated center, you're going to get the same care. Yes.
So I first was going to follow up Melinda's comment about policy changes. So, I mean, I think what we're all probably saying, and this kind of agrees with our clinician perspective, is once the patient has Medicaid, their treatment is similar, at least at a place like this. So what kind of policy changes can be done to deal with that very compelling data you have, that the pre-existing enrollees do well, the people who get diagnosed who get insurance at Medicaid at the time of diagnosis do less well? What can you do to fix that? Are states are not enrolling people as proactively as they can, because obviously that increased short-term costs, or is this something that we haven't figured out how to enroll those patients?
Yeah, it varies a lot by state, like everything else. So take Massachusetts. It has a very low baseline uninsurance rate, and in pre-ACA, they had a very low baseline uninsurance rate, and they were one of the first states to expand their Medicaid and offer a way to have insurance if you don't qualify for Medicaid to be able to get into it. And ACA was modeled after it. So they tended to do a really good job, but they had a low baseline uninsurance rate. So it didn't cost them as much to begin with. If you're in Alabama, where it's a state you don't have a lot of resources and much of your population is uninsured, there's not as aggressive approach to go out and get insurance. And Alabama is one of the states that have an expanded Medicaid. Not unsurprising. So it's more than it goes beyond the political philosophy, but what's the burden on the state budget then to go out if you have a large uninsured population and you're not a particularly wealthy state to begin with, and this is a state-run program? Those states are not as willing to go out and be aggressive about it. So Virginia just expanded not long ago, and they are really worried about the out of the woodwork phenomenon, that if you offer Medicaid now, all these people who now know about the program are going to seek it and really increase it beyond what they thought. I don't know that states have really seen a huge bump in that way. Just depends. A lot of it is going to be and politically this is so hard to do, but it's to nationalize these programs and standardize them across the board. Yeah, Carrie. Oh, sorry.
Thank you so much for your visit, talking for your body of work. Reassuring with regards to the value of data and the importance of Medicaid. Question, I just wanted to ask you to take a step back as someone who's been working in this field, specifically Medicaid, for quite a while now. It's just a troubling trend nationwide. 50% of all Medicaid beneficiaries nationwide are now covered by a privately insured plan. There's 5 companies, 5 Fortune 100 companies are now basically managing their 50% of our Medicaid beneficiaries. Their revenues of those 5 companies range from 30 billion for Molina's over 300 billion for United Healthcare. So just want to ask your thoughts about privatization of Medicaid and what's driving it and what we can do about it.
Yeah, I mean, so this comes back to that last slide around replicate, right? And try to get those differences to see what privatization has actually done in these companies. And that's a great question to be able to do it. And, we can start, if you get we're still one state. If we were able to get APCDs and registries across several states and be able to make exactly those comparisons, because we can identify what insurance company it is and find all of that information out around. I can look at whether they have a high deductible plan or not. And be able to make these kind of comparisons and to be able to look at what's happening in the Medicaid population. Great question. And I'm sorry, I didn't see that you had it.
No, fine.
Right.
Thank you so much for all of this. My question comes sort of to, as we've seen some really, really impactful advances in, cancer surgery, immunotherapy, targeted therapy. What are sort of the methodologic challenges to taking this same approach to something that maybe actually has a bigger impact on outcomes, but that is not as simple as, did you get referred for radiation? Are these things going to be able to be approached from large databases, or are you going to need more granular work in single counties or something to address something like that?
Great question. I think, and the reason we looked at hormonal therapy is because it's oral outpatient therapy. And we actually was looking at immunotherapy too, but the sites of it, we're not a huge state in terms of population. And so when you get out into our rural areas, the end gets really teeny tiny. But immunotherapies in these oral treatments are really underreported to registries for obvious reasons. And you're going to need to get these claims data from other kinds of sources. So you're right. As we make these advances and they're doing more and more in the outpatient setting, the data challenges get much greater. Yeah. And Tim.
It looks like we have one on Zoom as well.
Okay.
Where? How do you do it?
I don't even know. Where's the mouse?
Here's the
Oh,
mouse.
there it is.
Right. It's the only reason why a patient with the same socioeconomic status was able to qualify. Yes, that with a known cancer diagnosis, the question is, isn't the key issue that in some states, a known cancer diagnosis is the only reason why the patient with the same socioeconomic status was able to qualify for Medicaid. So, and I don't know for sure if I'm interpreting your question correctly, but first and foremost, cancer is not a qualifying condition for Medicaid unless you're diagnosed through the CDC program. Cancer does not get you on Medicaid. You still have to spend down if you're above the income requirements to be able to get into the Medicaid program, or to have qualified all along, just simply not knowing it. But for many people, there is a spend down period that they have to go through and get onto the program, and then they get the coverage that they need. So the SES, it's the same. If you meet that threshold within a state, you could be similar socioeconomic status, but still have to spend down some assets to be able to bring into the program. And I'm not sure if I answered that question exactly, but I hope so. Or if not, there's a follow-up. Tim.
Great talk. It's more of a philosophical, political question, but with Medicare, you mentioned the importance of maybe having a nationalized program. Medicare, we had it nationalized, but Medicaid, we don't. Do you think there's any fundamental differences between the programs that have prevented that, or is there a path forward to getting a national approach to Medicaid?
Yeah, I don't know. If you think of all the challenges to the ACA that's already been. I was a moderator for a panel with the National Cancer Policy Forum where we brought together for the 10-year anniversary of the ACA, and we were talking to Donna Shalala, the people who really were at the table when they crafted the ACA and brought it forward. And the question I asked them was there something you'd do differently? And the answer was, yep, we would not have compromised. That when we ended up, because we compromised on so many places in the bill in hopes for bipartisan support. And when it passed, it went right down party lines, not a single bipartisan vote. So their answer was the reason the ACA isn't what we wanted it to be is because we compromised. And if we did it again, we would not have done that because they were never going to play ball. So you're going to have a different, so it's a heavy lift. And I think the evidence that we provide and the care that we put in our research is so critical, and that we keep just pushing, that we have really valid findings. We're being more creative with our data. We're finding this and putting it out there in hopes that there's an audience.
Well, thank you so much. I'd like to
Thank
take
you.